Thank you. Good afternoon. So there were three surgeons in the hall, and two of them were sitting together, me and Dr. Dalong. And after the presentation, we realized that probably surgery is the easier part. You know, you do it and you get over with it. We don't have to second look into the reports or anything, and we just get away with a lot of things. Having said that, we also realize that medical oncology is like a Supreme Court judgment. You know, you ask three different judges, they'll give you three separate judgments, and the patient has to accept, or the litigant has to accept whatever is to there. So today I am to discuss a very broad topic. I have tried to shrink it into 30 minutes. I'll keep to pertinent questions, not the very obvious ones. But what happened with Dr. Ullah's panel is that they took all the medical oncologists, but thankfully we got the glamour. So Dr. Aparna Dhar is here to fill the role for a molecular oncologist bar a medical oncologist for us. But we were fortunate to have a very balanced panel with two surgeons and two radiation oncologists, and Dr. Aparna Dhar to play the referee's role. But I happen to know all of these guys very well, and they will bash me up if I do a very animated panel, unlike Dr. Ullah says. So I'll just try to keep it to minimum. Three of the panelists have cold, including me. So disclaimer, my M's will sound my M's and F's will sound my F's. So I'll just try to keep it simple. So define early lung cancer for us, Dr. Dalong. You know, this is a very broad classification, but if you were to look at early lung cancers, which one would you actually take out of these?
Shubham, I think we have moved very much ahead in surgery also from the era of what you call doing surgery for specific groups. Now we have moved slowly towards stage 3A, more acceptable now. So if you see at ESMO, the guidelines, if you see in the beginning, they just talked about metastatic disease. Slowly they talked about early and locally advanced, and then they talked about the role of Pacific specifically. And now in the latest, you can see that early lung cancers are all which are resectable, 3A, they all come under early lung cancers.
Right. But, for the sake of discussion, we will not include 3A as a part of it because, then our radiation oncologists will be, we will not have a point to discuss her. So we'll stick to up to 2Bs and probably 2As. But yes, for us surgeons, anything which is resectable becomes early. But if I look strictly at early cancers, I would try to stick to N1s only, and obviously lesions which are upfront resectable, probably up to 5 centimeters. But yes, as Dr. Dalong said, T3s are something that we jump at as surgeons if we find them to be operable upfront to begin with. So I picked up a case which was similar to one that we are discussing. We want to discuss. It's a 68-year-old gentleman, ECOG1, never smoker. CT scan showed that pretty little small mass, 3 into 2 centimeter in the right upper lobe, which on PET scan was given to be a 1.8 into 2 centimeter with no distant mets. There were no significant nodes also, with the biopsy showing adenocarcinoma. So my question to the surgeons first, Dr. Virendra first, followed by Dr. Dalong. What further information would you want to decide management of early lung cancer? Obviously, we are looking towards a surgical patient. So what information would you want? So the information that we have is a 68-year-old gentleman, never smoker, with a resectable mass.
Looking at the available images, it looks like a peripheral T1N0 disease. As far as staging is concerned, I think this much is enough. We can avoid MRI brain also. And again, coming to staging, medicinal staging also can be avoided as it is peripheral T1N0. So staging is over, and biopsy also you have already given, it is adenocarcinoma, that is also done. Now we want to further go ahead with functional thing if we are planning for a surgical thing.
Right. So what functional would you want?
So for any lung resection, basic minimum is to get a effort tolerance of the patient on history itself, whether it is 2 flight, at least minimum what we want is a 2 flights of stairs climb. If that is there, then the next thing is to go ahead with a cardiac as well as pulmonary evaluation. In pulmonary, we'll have a PFT and DLCO. We also get a small thing like what we called low technology exercise test, that is 6-minute walk test done in our OPD. So PFT, DLCO, 6-minute walk test, and for cardiac thing, 2D echo and ECG.
Right. Dr. Dalong, does 6-minute walk test still come somewhere in your list of workup when you are getting a PFT, DLCO, everything done for the patient?
Yeah, I mean, if you can do a complete PFT deal, so it's normal. I would really skip the 6-minute walk test. Unless you can't do that, I mean, some cases they don't, I mean, comprehend the pulmonary function test. So in that case, 6-minute walk will be very helpful. Besides this, I would like you to do a contrast MRI brain. It's a policy that we follow in our setup that all cases, especially adeno-CAs, we might have some silent mats sitting down, which could be solitary.
So is there any...
And that will basically change the whole management. I mean, surgery will be part of the treatment, taking as an oligomats.
Right. But is there a size criteria or is there a stage criteria for MRI, or is it for any curative resection you would want?
Yeah, any case going for curative resection, we'd like to get an MRI brain done.
Right. So actually, Virendra has already answered the first bit of my next question, that about invasive mediastinal staging, where there is enough data to suggest that for a peripheral less than 3 centimeter with a PET scan showing N0 lesion, you can get away by doing without mediastinal evaluation. But my question to Dr. Dodal is that would you also be happy not getting a MRI brain or getting a MRI brain for any size lesion, any early lung cancer, or would you always want a MRI brain to be done?
No, so for so early peripheral tumor, PET scan has already been done. There is no nodal metastasis. So in absence of any regional node, direct silent brain mets, yes, there is a chance, but that may be very, very less. I cannot advise MRI blanketly to each and everyone.
Right. For a curative treatment. Right?
Yes, for a curative treatment.
Okay. What about you, Anil?
So as a policy, we would advise MRI brain for all the patients, even if it is less than 3 centimeter. Similarly, as Dr. Dalong has said, if we can find, or if we could find the MRI brain 1 or 2 metastases, then the stage automatically changes from stage 1 to stage 4.
If we will get a MRI brain, the stage will change. But the question is that will you get a MRI brain
Yes,
for
always.
a 2 centimeter lesion, or
Always.
will you not get a?
Always.
You will always get. Right. So I was also of the same school of thought, but then actually, if you look at the data which is there and the more and more evidence which is there, they are trying to preclude not doing a MRI brain, a contrast enhanced MRI brain for very early T1A lesion. So this actually amounts to less than a centimeter lesion. So probably for a 2 centimeter one, yes, there is a role to say, but it is, I think it's not correct to say a blanket MRI brain for everybody. Probably very early lesions, 1 centimeter GGOs we can probably avoid, but definitely for a 2, 2.5, 3 centimeter. So not all T1s, but the very early T1s we can get away by not doing. So this is actually, this has to be incorporated in the practice, because what me and Dr. Dalong was discussing is that the amount of investigations, the preoperative investigation that we as surgeons require to get a patient on table are so humongous that the patient actually either progresses or loses confidence in the team, or, you know, they get so many multiple opinions that they actually do not come to that table, and we miss that part of the treatment part, which is actually the most important part.
Yeah, like Shubham, that part, we have got a system, we got a package system. You know, when you do a PET scan for lung cancer, we include CMRI brain as part of the package in the same setting.
Same setting?
Yes, we don't do it separately. We do a PET CT with MRI brain in the same package.
Irrespective of stage for all the patients?
Yes, in CA, in
mean-
CA lung.
I mean,
Just to
forgetting
avoid
about
that,
the cost part.
Yes.
I mean, is it needed? I think that is what we should consider. Is it needed for each and every small T1 peripheral, no nodes on PET scan? Should we do
No.
MRI?
So that's what Dr. Rudel, there is enough data, enough evidence. I've just shown one of the publications here, which says that for a 1A lesion, T1A lesion, you can get away without doing a MRI brain, but that T1A is actually less than 1 centimeter. So the percentage of patients who come with T1A lesion is very low. But what Dr. Dalong is saying, that for any other lesion more than 1 centimeter, which is the usual practice, probably getting it at the same time, packaging it together might be a better option. So, Dr. Anil, does it matter to a radiation oncologist what's the PFT of a patient, or if the patient is just walking around, can speak, breathe, we can give radiation?
No. Yeah, it's always matter what is the PFT of the patient and what is the pulmonary function test and the general tolerance of the patient, because a lot of the radiation parameter, the planning parameters will always depend upon the pulmonary function test parameter. If you have a DLC of approximately 20 or 25%, you will always counsel the patient likewise. If the patient is having a DLC of more than 40%, then we do not have any problem. But we need to find out. So because for the majority of the patient will come to us with a PFT report because it would be medically inoperable. So it's always important to look at the PFT parameters, because the radiation pneumonitis, even if it is less than 10%, if the DLCO gets low or decreased by more than 10%, the patient will be symptomatic, and you need to counsel the patient pre-radiotherapy that the patient can have some decrease in the DLCO. So as a policy, we do PFT. Yeah, even if it is not been done by the surgical oncologist. For example, heart disease patient, they say, oh no, it's completely inoperable. We don't want to surgery, but we don't want to operate. Still, we will get the PFT report.
But Dr. Dodul, is there you change your treatment planning with reduction if the patient presents with a low PFT or a poor DLCO? Do you change your radiation planning in terms of giving reducing the field or avoiding some certain areas, but if the PFT is poor?
Yes, so that depends on the tumor anatomy and location, and of course the size of the tumor and expected volume of lung, which will get significant dose of radiation. So if the volume of tumor is very small, even when the PFT is not so encouraging, suppose a vital capacity of 700 ml or more, so that is quite acceptable. But if it is less, and still if I find this tumor is very small, so I do not expect too much of morbidity out of radiation pneumonitis, because the effective volume of lung parenchyma getting exposed to radiation will in any case remain small.
Right. So there are enough evidence to tell us that probably there is a significant reduction in the pulmonary function test values even after a SBRT. So it might be pertinent to hold a radiation oncologist up against whenever they say that, probably radiation is a safer option. But I want to get Dr. Aparna here into that. Dr. Aparna, before we decide into the management of the patient, right now we are going to the treatment part, but before we decide the management of the patient, is there now enough data to tell us that we should get a molecular testing done at this point before committing to a treatment?
So in early stage, and I'm just looking at stage 1, stage 2 as
right, definitely. That's what we are talking
about. Look at that post-surgery, depending on the staging, if the margins are not involved, if it's no negative, in a case like that, we do have data where we've seen that EGFR, especially in those high-risk patients, testing for EGFR can be beneficial along with or without chemotherapy.
No, but if we are going to resect it, we can do that testing after resection.
That's right. Before we don't do it.
So would you want to get testing done right now?
No.
Okay.
No.
What if this patient was medically inoperable and was not gonna go for a surgical resection, but just for a radiation probably? Mm-hmm. Would you want to get a molecular testing done for this patient now?
I would do it it's not ideal in the guidelines, but I would still, in our practice, and I've seen our medical oncologists do it, that when they cannot go in for surgery, they do a biopsy and then maybe consider molecular profiling.
Anil, is that a practice that, we know that the patient is not going to be operable?
So we routinely don't do it for the EGFR or whatever we call it as a ultra small or small gene panel, but we would refer the patient to the medical oncologist just to let them aware that this patient has been treated with SBRT and this is an adenocarcinoma patient. So in the future, if the patient develops any distant metastasis, so whether the tissue which is available to us at this moment of time is adequate or not, they will decide. But we routinely don't do EGFR or
so my point was that if you give radiation and then the patient goes, then they will not be able to retrieve more tissue.
Yeah, I know.
So we have to ensure that they have enough tissue beforehand instead of sending them after radiation. So that's what my question is, that would you send the patient before starting radiation, that do they have enough tissue for a testing, or would you send it afterwards only once you have finished radiation?
We generally don't send the patient to the medical oncologist if this is an SBRT patient, because generally they don't do the adjuvant chemotherapy as far as the standard treatment is concerned. The adjuvant chemotherapy is not recommended, and there is no data as of now for adjuvant immunotherapy after SBRT. So they will not do.
Right. So that's why my question was that would you actually get the testing done right now? And
So, Dr. Batra, in how many early lung cancer patients you send the patient for neoadjuvant immuno? And how about the efficiency of liquid biopsy in this setting?
And do it for the EGFR.
So, do we really need to be too much concerned about getting a tissue upfront, or can we rely on liquid biopsy as well?
You have a tissue, no? You do a biopsy upfront. So why not?
So,
I mean, what is
definitely all patients undergo biopsy before giving
Yes,
that
so do
definite
we need
treatment.
I'm talking from a medical oncology perspective. You have a biopsy similar to a stage 4 lung cancer patient. Your biopsy, at least do an EGFR ALK if you are contemplating giving immunotherapy to that patient. I mean, that's a rider.
So I
If you're
think-
not
I
giving
think the-
immunotherapy, that's okay.
yes, so I think what I also wanted to highlight was that if we are going to commit to surgery first, then probably tissue will not be a problem anyways. But for anything else, even for SBRT, that is what my point is, because see, even if you're giving SBRT, 2 years down the line, 3 years down the line, you might have that
So
issue that
Shubham,
the
there
tissue
are,
is
there
not
are two
available.
issues. There are two issues. One, 2 years down the line, SBRT, what he said was right. You don't want to give any adjuvant treatment, so you can forget about it. My question specific was with Checkmate 816 and AGIAN study, new adjuvant immunotherapy is going to become a standard of care. And there the major issue is going to be, we know immunotherapy does not work in biomarker positive patients. At least do an EGFR, I'll rule that out, because otherwise, like we initially started giving immunotherapy to everyone. And now we have said biomarker positive, it doesn't do.
Right.
So wherever you are giving, let's say adjuvant immunotherapy, forget you got a surgery done, you have given 4 cycles of chemotherapy. And will you give adjuvant immunotherapy, pembro or atezo to a patient who is ALK rearranged? So, it can be a negative biomarker also. I mean, a positive biomarker can be a negative predictor also. So we need to do this testing. Yes, Dr. Aparna.
I just had a question. So in your practice at RGCI, stage 1, stage 2, are you guys upfront doing molecular profiling?
We do.
Oh, I'm doing that so I can take it back.
No.
We do. Yes, we do.
Yeah,
So that
for all
is
the
a part
patient
of the
or for-
trial, right?
So we do as a part of a profile, research profile. But in clinical practice, that's what I'm very clinical saying. In clinical practice, if I am going to give immunotherapy to a patient, either who in the adjuvant setting or the new adjuvant setting, I like to make sure the biomarkers are negative before I go and burn my fingers. And patients,
So
whatever.
one more comment, if Dr. Shubham allows me to do. So this role of adjuvant chemotherapy is not actually strictly no after SBRT. So there are certain high risk factors which makes the patient eligible for adjuvant chemotherapy even after SBRT.
Fair enough.
So I
We
think
were talking about the biomarker
yes,
thing,
yes.
right?
No, I mean, this message is also should be clear that there are certain patients who might need chemotherapy even after SBRT.
Agreed.
So are we going to do for each and every patient outside of a clinical trial also?
So that is
My
what
answer
is
over here is,
so-
if you want to give immunotherapy to a patient in the new adjuvant or the adjuvant setting, please go ahead and do a biomarker analysis, at least a
Just a
EGFR.
So for any neoadjuvant therapy,
just a minute. In clinical practice, if you want to do a routine molecular testing like EGFR, ALK or ROS, if the report comes out to be positive, then what are you going to tell the patient? Whether you are going to give the osimertinib after SBRT?
So I will,
Say in routine clinical practice, it's not indicated. In research setting, yes.
right
It is
now,
indicated.
it's not a part of the routine, but with the evidence that is coming up, we might actually change our practice. That is what we're
So,
talking about,
I can
especially
tell
with the
you-
new Adora and
I
also
can
the
tell you
immuno.
one thing. So what you said was, so let's define the setting first. Let's say you're going on, let's talk about
This
surgery.
is, we are talking of early lung cancer. We are not even going to operate versus SBRT, but we are just there at the molecular profiling needed.
You should always have this thing present, just so that when the patient relapses, and they will relapse in 60 to 70% of the
That's
time.
my problem, that they will
When they
relapse, and even the
relapse,
surgical patients will relapse.
No, wait, if it relapses, the tumor biology can change on a relapse.
the
So you
driver
can't
It can change.
and
It
I
can
can't-
change.
These are the driver mutations, Dr. Apna. They won't change. And region lung cancer will not become negative.
No, but you can get other concomitants. So
get,
you
there
can't
is-
depend just on that. So when there
No,
is a
there is-
relapse, we would again do a biopsy and molecular.
That is definitely true. We will not rely on this report to do it, but at least these also act as
So my
prognostic
first
markers.
point is, why should we do that? If you're not going to rely on the first biopsy report, if the biology is going to be changed, then why are you going to do
The
before
biology-
SBRT? I'm not talking about surgery. I'm not talking about surgery.
Dr. Ullas is saying upfront when they are doing molecular profiling in first or second, especially if you are considering immunotherapy, it is important
Yes.
that we have that molecular information to make the
And B,
decision.
the point is the biology will not change in more than 10% of people. 90% of people it will remain the same. So just for the outliers, you can't change the normal thing. That's what I'm saying.
But the other fact is also true, sir, that whenever the patient progresses, you will get
Do
a.
a biopsy, there
Yes.
is no harm. But again, the tissue is always an issue. The time will come over there. So
I
if you have
I
a report, there is
agree.
no harm.
So, the molecular part gets really sucked us in and get everybody
So,
charged.
Shubham, I think what Ullas said is basically anything less than 2 centimeter, 1B, and will not do that. Anything more than 2 centimeter, because all the neoadjuvant studies coming up now are basically 1B and 3A. All
Right.
those
Dr. Dalong, how many less than 2 centimeters have we seen?
That's
it's very rare that we see.
Yeah.
So all those are definitely going to have a molecular marker done, because neoadjuvant IO, he said,
you have to let it.
it's coming in a big way. That's, I think, how we're going ahead.
Right.
So I think
So-
more than
so-
2
so I-
centimeter, we
I-
need that.
It's just to make it interesting. If there is no harm in doing molecular testing, is there any harm in doing MRI brain upfront? Even if for 2% or 3% of the brain metastasis
No,
that
no,
we will
it's not.
detect.
So, Dr. Anil, I
can
take it from your side.
So that's why I'm trying to tell you that in routine clinical practice, there is no need. In clinical research trial setting, yes, we should do whatever we want to do. But in routine clinical practice, no, there is no need, because even if that is positive, you are not going to act upon it. And if we are post SBRT setting, I am a radiation oncologist, I will talk about the SBRT. If there is a recurrence in the SBRT setting, majority of them will have a recurrence in the distant location where you can
Right.
get the biopsy from. Okay. So if we are not going to rely completely on the
So we are
initial
talking
biopsy
of a
report,
scenario, Anil, where immuno will be a part of a
it
neoadjuvant
will be a part.
setting.
It's not a part.
So, Dr. Shubham, I
that's
think
what I'm trying to
we cannot set a standard right now, waiting till the time the data is not available. So as of now, if we talk about what should be the standard practice in clinical scenario,
No.
we
I
should
will
follow
differ,
the
sir.
standard
One
guidelines
second,
as of
one second. What data are you
So-
talking is not available right now?
No, I
In
mean,
adjuvant, one second.
the
What
role
data
of-
you are talking? No, one second. What data you are talking in adjuvant setting?
So no, we are talking
power-
about neoadjuvant immuno.
So in
So
checkmate
new
data-
scenarios. So
checkmate
Dr. Bhatt, we are
816.
talking about two scenarios: early cancer, neoadjuvant chemoimmuno, early cancer, post SBRT adjuvant treatment.
So
So that is where we are discussing today.
I am not talking about SBRT right now. I'm talking about surgery. In surgery, you have done a surgery, a stage 2 surgery, a node positive surgery. There's enough and more of data that a PDL1 person will have. You give 4 cycles of chemo, then give an IM power
Yes, so
010
stage 2B.
regimen. It will
I think you are
benefit.
talking about stage
Sir,
2B
yes.
scenario.
In surgical operable patients, again, as a part of, even TMH is a part of Neodura. As a part of clinical trial, we are doing EGF.
Let's forget about clinical
But
trials. Let's forget about
otherwise,
that.
still we are not as a routine doing molecular analysis in a early operable,
Can I
in
again
a
ask you a
pre-treatment.
different question now?
Yeah.
Let us say you have a stage 2B patient. in which you have, these things there, whether you will want to give immunotherapy or ADAURA trial, how will you decide?
That you have got a specimen, you can do molecular analysis on the
So you're
resected
doing right?
specimen. Yes.
You're doing right.
If,
That's
yes,
what we are saying.
that is what I'm trying to
that
say.
is
what I'm also
In a
saying
biopsy specimen,
So
on a
that
biopsy
is
specimen,
post-resection.
is not needed if patient is planned for
Shubham,
surgery.
we are out.
Not for
The radiation oncologists are out.
out.
Yeah,
Data in
another one thing. I mean,
say those between surgery and SBRT, surgery is better.
I mean, if something is not doing any harm, should we
I can
continue
debate on
doing
that.
all these things?
No.
Many things cannot
Dr.
do any
Dodo,
harm.
the next question is for you. I just need one word answer. Okay, no explanations. If PFT is okay, cardiac functions are okay, what's the ideal treatment in early medically operable lung cancer?
So I wish SBRT was in the forefront, but as of now, we should recommend surgery only.
Great. Dr. Anil,
Yeah, I agree that.
you have just deflated the panel. I thought you will be combative and tell that, SBRT.
I told that I wish SBRT
only
was in
5
the
minutes
forefront,
late.
and the
We are only
surgeons
5
send
minutes.
their patients to us, and we could show that SBRT is actually probably more efficacious than surgery.
Right. So with these submissions of yours, I'll move back to the surgeon that what ideal surgery would you offer to such a patient?
Lobectomy with the systematic nodal.
Yes. So that is still the standard of care, that lobectomy with the systemic mediastinal lymph node dissection. And Virendra, can you just elaborate on the systemic mediastinal lymph node dissection also?
So for this case, it is a right upper lobe. So 2R, 4R, 7, all hilar interlobar.
Right.
Node along inferior pulmonary vein as well as paraesophageal. That will come into systematic nodal clearance for a right-sided tumor.
So the mediastinal nodes that we have to at least have 3 stations included, which includes definitely the 2R, 4R, 7, and obviously all the hilar nodes, that has to be a part of it. I will skip this part, Dr. Aparna, sorry, because can we offer some other surgical treatment less than a lobectomy, Dr. Darlon?
Presently, we have the Japanese group JACOC 802, which came recently. It was basically more for ground glass lesions. I mean, CT ratio about more than 50% with soil components and N0. So in that, what we saw was basically in terms of OS and in terms of lung function preserving. In terms of OS, it was found to be superior compared to the lobectomy arm. But in terms of preserving the lung function, it was just 3%. But there's a lot of caveats in that, because those who changed the thing was basically the mortality was more in the lobectomy arms because of cardiac reasons, pulmonary and neurological reasons. So, I mean, the question is still open, and I would still prefer a lobectomy.
Yes.
Because it was Japanese study was mainly for ground glass partly solid lesions.
So
I'll still be towards lobectomy.
I think the question is still out in the open, because both of these trials were a non-inferiority trial. They just showed that sublobar resections may be comparable to lobar resections, but they have not still shown a superiority. However, we have problems with sublobar resections. Virendra, can you elaborate on the limitations that we have?
So main problem of sublobar resection, if you're talking about wedge, it is easier to perform. But if you're talking about segmentectomy, all segmentectomies are not simple. Segment 6 is fine. Left 1, 2, 3 is fine. But if you go for 8 and 9, they are difficult segment to resect. That is one thing.
Other than surgical technique wise, the problem with segmentectomies, I think it's more to do with patient selection, because the size of the lesion has to be very small.
So till now we have evidence only for 2 centimeter or less.
Yes.
Anything more and 2 centimeter less and node negative. So sampling of hilar and all, if node negative less than 2 centimeter, then only recommended. Otherwise, no.
Right. So which actually brings us to the question that, if the PFT is borderline, cardiac functions are borderline, then what would be the treatment for choice in case of such a medically inoperable lung cancer? You have to say it by your own self that SBRT is better, sir. You have to say it. You have to say it. No, you have to say it.
See, you already wrote there it's medically inoperable.
Yes.
Obviously, SBRT becomes the choice.
Right. So, but my question is that would you be happy to offer a sublobar resection if the patient is not fit in terms of PFT, or would you be happy to send them to SBRT? So the question is SBRT versus a sublobar resection and not SBRT versus a lobectomy.
A DLCO somewhere around 60%,
Right.
40 to 60. You mean that? And if the lesion is again peripheral, not and sometimes if it's in the middle lobe, I think that will be more easier to go for a lobectomy, middle lobectomy. It's a small lesion.
Right.
And if it is in segment 6, it's also much easier to go for it. But it's somewhere like in the segment 8, 9, there, I mean, the more lung is going to be not preserved more. In that case, I think SBR will be more preferable.
Anil, would you prefer, sending a patient for a sublobar resection, segmentectomy, spending more time, getting doubtful margins, or SBRT would be a better option?
So, as far as the evidence goes, there is a current ongoing trial called the Stable Meds, where they're evaluating the sublobar recession versus SBRT in less than 3 centimeter, I guess. But if you are considering for the patient who is medically inoperable and you still want to do sublobar recession, but you still have doubts whether the margin will be positive or the recession would be complete or not, then I would suggest that SBRT will be an equally effective treatment without much side effect if the patient cardiac function is not good or the pulmonary function tests are not good. So SBRT will be slightly superior as compared to sublobar recession. However, the evidence is still lacking.
Right. So actually, this is where the debate is that for a medically operable patient, we still have to decide between lobectomy versus a sublobar resections. Pure thoracic surgeons, they are moving towards a sublobar resection. It might have a sway, but still the evidence that we have is just a non-inferiority and not a superiority. But even the surgery versus SBRT, there are still 2 trials we are waiting the result. Sir, Dr. Vijay.
Data, I think I'm loud enough. If you go for sublobar resection, I'm hinting to a data which came in JAMA Oncology a year back, that the indications for adjuvant chemotherapy would change if you go for sublobar resection. That was the big CR data weight analysis, which they suggested that the cutout doesn't remain 4 centimeters, but it comes down to 3 to 4 centimeters with presence of either PNI and intravascular.
No, so the issue with sublobar resections is that the current data suggests that, we have a CT ratio where if you're doing a 2 centimeter resection, you have to go 2 centimeters on either side of it, which makes it a 6 centimeter lesion, which is anyways beyond a segment. So that is why the limitation right now that we have is up to only a 2 centimeter lesion. Can you offer a sublobar resection? But this is where the debate is that would it be better to do a sublobar resection for a borderline PFT or to offer the patient SBRT when the SBRT is showing you similar results as compared to lobectomy in a lot of retrospective trials?
I have one question for Shubham, for you and Dr. Darlow. Neoadjuvant immunotherapy.
Right.
Why not?
I thought we are not denying it. Who is denying it?
I'll be talking about that
Yes,
next.
we are.
Yeah.
We were not denying it. We were just debating that it is still not a part of a routine practice.
It's a New England Journal of Medicine paper which has shown a good DFS benefit.
Shubham, my talk is on that after this. Yeah.
We are here. Thank you so much. Thank you so much.